I'm David Hubbard, our first speaker. This is a section on perfusion and flow. Our first speaker, I do not want to pronounce it badly, even though she helped me practice several times. Vida Demarin is a professor of neurology in Croatia. I probably could have done a little better than that, but I was afraid I was going to mispronounce some of the words.
Colleagues, is it functioning? Yeah. I would like to express my gratitude to the organizer who invited me to review with you some of the data related to stroke and brain perfusion. I have nothing to disclose. You know that stroke is the second most common cause of death, with 16 million cases occurring in developing countries. Stroke represents an enormous burden on global health, and it is a major cause of disability. Ischemia is restricted blood flow in the main cause of stroke, typically due to occlusion of a cerebral artery as a result of progressive atherosclerosis, often because of uncontrolled hypertension or diabetes, or an embolus from the heart or neck vessels. Just to remind us about the cerebral blood flow, it is determined by cerebral perfusion pressure and cerebral vascular resistance. Cerebral vascular resistance is determined by the diameter of the intracranial arteries and also blood viscosity. Cerebral perfusion is a high-flow, low-pressure system with relatively preserved diastolic flow. Anatomical features and functional responses are also due to cerebral autoregulation. In conditions where cerebral perfusion pressure remains constant, any change in cerebral blood flow must result from a change in cerebral blood resistance, usually as a result of alteration in the diameter of the small intracranial arteries, which are the predominant resistance vessels. In pathological states such as cerebral ischemia, correlation is disturbed. I will just say a few words about physiological mechanism of autoregulation. It's myogenic hypothesis and metabolic hypothesis. Cerebral autoregulation, I will not bother you too much. Now about anatomy of collateral circulation. You know that collateral circulation is a very important thing. We have three principal anatomical features that underlie collateral perfusion to the brain. It's extracranial arterial collateral circulation, intracranial arterial collateral circulation, and leptomeningeal anastomosis. Blood flow is also regulated by intrinsic and extrinsic innervation of the blood vessels, stimulation of sympathetic nerves, especially in the region of the locus coeruleus, and parabrachial nucleus causes reductions in cerebral blood flow and brain water permeability. In acute ischemia and collateral perfusion, there are several changes of course. Animal studies suggest that systemic blood pressure can affect the magnitude of this gradient and ability to stimulate collateral recruitment. In patients with acute ischemic stroke, a history of systolic hypertension at the time of admission was associated with poor collateral circulation, and previous use of statins was linked to better collateral circulation. So chronic hypertension might downregulate cerebral autoregulation, leading to poor collateral vessel development, whereas the use of statins could enhance new vessel development mediated by an increase in endothelial progenital cell growth. Factors that could have an important effect on the robustness of collaterals. In the case of occlusion, we have severe intracranial arterial stenosis, was also shown to be an important determinant of PL collateral circulation in VASIT trial, and patients with mid to moderate intracranial stenosis did not have the same degree of PL collaterals. We also speak about border zones. Despite collateral supply, there are regions of the brain that are particularly vulnerable to a fall in perfusion pressure. Such border zones areas include those at the boundaries between the anterior and the middle and posterior cerebral arteries, and the internal border zone areas in the corona radiata and centrum semiovale. These arteries and therefore ischemia in their territory results in more rapid cell death. We know that there are high metabolic demands of the brain. Brain uses almost exclusively glucose as its sole substrate for energy metabolism. Since brain is unable to store energy, it requires a constant supply of oxygenated blood containing an adequate glucose concentration to maintain its function and structural integrity. The brain oxygen requirement in the adult body, human accounts for about 20% of that of the whole body and for relative size of only 2%. High metabolic demand is matched by a disproportionately large amount of total cardiac output passing to the brain. There are some local coupling, and of course nitric oxide is important in basal CBF. We here have critical flow thresholds. A threshold for loss of neural and electrical activity is about 16 to 18 milliliter per 100 gram per minute, and for loss of cellular ion hemostasis in 10 to 12 milliliter to 100 gram per minute. The threshold for infarction appears similar to that for energy failure of membranous hemostasis, but it varies with the duration of the insult or stroke. Excitotoxicity appears to play a crucial role. Glutamate release activates postsynaptic NMDA and AMPA receptors. This results in calcium and sodium influx in the cells, leading to cellular edema and activation of the catabolic processes that destroy cellular integrity. Increase in intracellular calcium through activation of voltage-mediated calcium channels induces protease kinase and a calcium modulation regulated enzyme. We speak about critical flow. Here you can see just graphically that protein synthesis decline when cerebral blood flow is diminishing. Then we have selective neuronal loss, glutamate release, pH is decreasing, ATP depletion, infarction, and then anoxic depolarization. Here, cerebral blood flow is very sensitive to changes in blood CO2 concentration, largely mediated by concomitant changes in the pH of brain tissue. Reducing of arterial PO2 results in an increase in CBF, whereas an increase in arterial PO2 above normal values has a much lesser effect. Hypoxia appears to act through a direct effect on cellular resistance vessels and through indirect effects including the release of vasoactive factors. Clinical relevance of hypercapnic response is also, of course, very important. It is widely used to estimate cerebral perfusion reserve in patients with carotid stenosis or occlusion. Tests may identify patients with carotid occlusion who benefit from extracranial intracranial bypass, and reduced hypercapnic response ipsilateral to carotid occlusion is associated with an increased risk of stroke or transient ischemic attacks. Cerebral circulation response to focal ischemia is like this, that cerebral perfusion pressure can fall because of systemic arterial hypotension or severe stenosis in extracranial or intracranial supplying arteries, or a combination of the two. As CPP falls, intracranial resistance vessels dilate to maintain cerebral blood flow in the same condition. This results in an increase in cerebral blood volume. When vasodilatation is maximal, further falls in CPP result in a fall of CBF. Because oxygen delivery to the brain normally greatly exceeds demands, metabolic activity is maintained initially by increasing the oxygen extraction fraction from blood. When oxygen extraction becomes maximal, flow is inadequate to meet metabolic demands, cellular metabolism is impaired, and the cerebral metabolic rate of oxygen begins to fall. In acute cerebral ischemia, we have brain tissue is delicately sensitive to ischemia because of the absence of neuronal energy stored. This acute ischemia may result in a central irreversible infarcted tissue that is surrounded by a peripheral region of stunned cells, and this is called penumbra. Evoked potentials in the peripheral region are abnormal, and the cells have ceased to function, but this region is potentially salvageable with early recanalization. Here we see this core and penumbra, and all our efforts in therapy are, of course, directed to penumbra region. And also, I will skip some of these slides not to bother you too much. Of course, we have now possibility with nice imaging to image core and penumbra, and with all this perfusion and also fusion possibilities. Here we see role of CT in acute stroke evaluation. There is an Alberta stroke program for CT scores aspects. It was determined that the baseline access correlated inversely with the National Institute of Health score, and as these aspects decrease, the probability of dependence, death, and symptomatic hemorrhage is increasing. CT angiography is also very important, and CT perfusion imaging. You see here core and penumbra that is very nicely seen in this CT perfusion image. Magnetic resonance is really of the most important. We have all these exogenous contrast methods and endogenous, and this concept of diffusion perfusion is very important because it shows us which patients are candidates for further therapy. So this diffusion perfusion mismatch, really tissue that is abnormal on DVI and has low perfusion is destined for infarction, and that is within 6 hours of stroke onset. Approximately 70% of acute patients will have a perfusion volume greater than diffusion volume, 20% will have equal volumes, and 10% the perfusion volume will be smaller, representing spontaneous reperfusion. Collaterals are very important, as I told you before. Neuroimaging techniques, particularly CT and MRI, allow identification of cerebral injury in the first few hours after arterial occlusion in patients whose tissue survives for a long period despite proximal arterial occlusion. A retrograde filling of PL arteries, a surrogate indicator of leptomeningeal collateral vessels, is often evident in imaging studies and might have an important protective role. Enhancement of blood flow through collateral vessels might be therapeutically useful in the treatment of acute stroke. We have some trials now that have shown us that it is how important it is, this collateral circulation, and I think I don't want to bother you too much with that. Then, of course, pattern of leptomeningeal collaterals are strong predictor of stroke outcome. So presence of leptomeningeal collaterals on CT angiography was associated with later infarction changes on admission, non-contrast, so showing higher aspect scores. Similarly, patients with equal or greater scores had lower 6 months mortality than did those with lower collateral scores. Cerebral revascularization, of course, is definitely very important. What is of therapeutic value? We now have intravenous thrombolytic treatment for patients that come to the hospital within 3 and now 4.5 time windows, but this is really just a few percentage of the patients, so we are still not definitely satisfied with acute possibilities of thrombolytic therapy. Then also we have intra-arterial thrombolysis for those patients that are seen in cerebral imaging having penumbra and intracranial thrombus with penumbra, so we will consider intra-arterial therapy for them. For those where we don't see penumbra and don't see thrombus, then intra-arterial therapy might not be useful. And also we have some experimental techniques aimed to increasing cerebral blood flow, like volume expansion with or without increased blood flow pressure, stimulation of sphenopalatine ganglion, partial aortic occlusion, just A few words about mentioning this volume expansion is on the basis of available evidence, still not accepted by American Heart Association guidelines, and vasodilators as well. Induced hypertension was considered to be used just in really exceptional cases, and that cardiac and neurological status should be closely monitored. Then we have sphenopalatine ganglion stimulation. The sphenopalatine ganglion is accessible from the oral cavity and is amenable to electrical stimulation. And experiments in animal focal ischemia models have shown that stimulation of this ganglion increases blood flow and reduces infarction volume. Treatment effects have been shown by functional behavioral tests, MRI measures of infarction volumes, and histological study, but still in one open-label pilot study indicated that treatment seems to be well tolerated in patients with acute stroke, but still it is not very much present in real life. Then also partial aortic occlusion is important. Augmentation of blood flow to the brain by the restriction of the abdominal aortic blood flow was initially tested in animal models. So we have temporary occlusion of abdominal aorta above and below kidney. Catheter is capable of restricting. It is called NeuroFlow. This catheter has also been tested in patients, initially treated with intravenous alteplase, and it does not seem to be associated with an increased risk of hemorrhage transformation. Here then, there are some external compression devices that also like anti-gravity suits and external counterpulsation have been assessed in a few patients with acute stroke or subacute, and these simple interventions seem to be safe, but there are no data to lend support to their use outside the clinical trial settings. In summary, I would like to emphasize that in acute stroke, the severity of ischemia determines how fast brain tissue might sustain irreversible damage. PL collaterals, if well developed, might allow protracted tissue survival in the event of a proximal occlusion of large intracranial blood vessels. Imaging of collateral blood flow is challenging, but of course we need multimodal CT and MRI techniques. Perfusion combined with vessel imaging seem to be the most promising methods for the routine assessment and quantification. Research has shown that the presence of good collaterals leads to better clinical outcomes with intravenous and intraarterial reperfusion therapy. Important advances in the imaging of collateral blood vessels and collateral blood flow will need to be followed by a rigorous assessment of the therapeutic value of techniques aimed at improving or maintaining collateral flow in patients with acute ischemic stroke. Thank you for your attention.
Thank you, Dr. Demerin. Any questions?
Appreciate your talk. But one thing is missing, actually. So nowadays, interventionalists try to save this penumbra using mechanical thrombectomy, or at least intra-arterial thrombectomy. And of course, these results are very new and very preliminary, but the results are very exciting. It has been shown that even about 80% of this of this nervous tissue, which otherwise would be doomed to become death, can be saved.
This is true. I have just returned from American Stroke Association meeting in New Orleans, where Professor Saver was showing the results of SWIFT trial with this new device, and it was very good results, even better than Merci trial with this mechanical. I'm sorry, it was the other presentation that was put down. I have these slides on my...
Those of you who are planning to come to our next year meeting in Krakow, we are planning to have a full session. And I have already invited specialists from Oxford University in United Kingdom with very good acute stroke unit, and also doctors from Hamburg, Germany, with the Leiden Center in continental Europe.
True.
So if you can, please come next year.
Yes, I will do it gladly. Thank you.
Thank you.
Okay.
Thank you. Our next speaker is Dr. Yulin G. from professor at NYU, speaking on perfusion. Is there a pointer? This thing's the pointer?
Oh, this is the point. Oh, yes. Or can I change to the, okay. Hi, good morning. First, I would like to thank the Mark and also the Society for the invitation to this meeting. This is a great pleasure to be here. So, as you noticed, so I changed my topic a little bit, and because I noticed there are two perfusion imaging talks in this session. So today I'm going to try to talk about the oxygen delivery and also the metabolic abnormalities in EMS. So they're going to focus on two hypotheses from our group regarding the underlying mechanisms of the progressive neurodegeneration in EMS. So one is oxygen delivery and another is oxygen consumption. So they are all related to the nitric oxide overproduction in EMS. And we hope to try to establish the link between the white matter inflammation and also the progressive neurodegenerative changes. So we're using the in vivo imaging techniques, MR techniques, to measure the cerebral and metabolic rate of oxygen, CMRO2, and also this is the oxygen consumption, and also measure to cerebral vascular reactivity. This is the reactivity, not the resistance, as the previous speaker talked. It's also called CVR for the oxygen delivery. And I'm going to also include several slides of perfusion studies. And lastly, we're going to talk a little bit about the relationship between our measures and the CCSVI. So, as previous speaker mentioned, our brain represents only about 2% of the total body weight, but consumes about 20% of the total body oxygen. And there are some facts of oxygen metabolism. The oxygen delivery, since neurons do not have the internal reserve, so therefore they need instant oxygen delivery. And also the oxygen activity is dependent on the increased cerebral blood flow, or CBF, to deliver the oxygen. So this is well known in the neurovascular coupling mechanism. And oxygen metabolism is critical in brain, and also because they produce the ATP in mitochondria. And also it's directly related to the neuronal activity. So we know there are two hallmarks in imaging of MS. One is inflammatory changes, or you can call them lesions, white matter lesions, and also one is atrophy, or the neurodegeneration. So actually there's a missing link between this. We don't know why. The MS started with the white matter lesions, but it ended up with progressive neurodegeneration. So actually the neurodegeneration, which is play the key role in the progression of the neurological disabilities. So this is our hypothesis. So we think there are two pathways from the increased nitric oxide to the neurodegeneration. So we know the nitric oxide is produced and increased when there is a vascular inflammation. And actually MS, there's a lot of subtle or obvious, the repetitive, the inflammatory activities, always, especially in the stage of the relapsing meeting. So one, the effects caused by the overproduction of the NO is it can inhibit the mitochondria, the respiratory chain, and not let the oxygen uptake by the mitochondria. So even there is oxygen around the mitochondria cannot uptake. So it's kind of caused it's called the histotoxic hypoxia, or called the metabolic hypoxia. So the mitochondria cannot really produce ATP efficiently. So, but in the venous side, we can see the increased oxygen levels because there's less utilization of oxygen. So another part, the second pathway we think is because of the overproduction of the NO. The NO is a strong the vasodilator. So for the chronic or the long term, the NO, the increase, it can desensitize the neural. The vessel vascular smooth muscle, and disrupt the neurovascular coupling mechanism. So it also can cause actually the blood flow regulation problems. So it cannot efficiently deliver the oxygen because when the neuronal cells active, they draw the blood immediately. Once this mechanism is disrupted, they cannot draw the blood immediately, cannot have the oxygen provided immediately. So this is another pathway we think causing the chronic. This can be called the activity-induced the hypoxia. This activity-induced hypoxia mainly happens in healthy neurons. It's nothing to do with the lesions. So both the pathways create a condition like a chronic diffuse hypoxia, and then, of course, the neuronal axonal dysfunction or dead. So there's, even the oxygen is very important to our brain. There's only one paper actually published in MS World. This is in 1998 using the PET imaging. They found the regional decreased CBF and also the CMR2 is decreased too. So we know that compared to the PET, the MR, a lot of the advantages, especially the MR is the routine clinical imaging. So, and there's no radio, the active, the tracer used. And because the PET, to measure the oxygen metabolism using the O15, the O15 has to be very short half-life, has to be, there's on-site cyclotron. And also the study is lengthy and cost. I mean, the patient is also the problem for the patients. So there are a lot of, the advantages of MR, high resolution, high sensitivity to lesions, better quantification, multi-contrast, and multi-features, as shown here. So this is the famous images obtained actually 20 years ago. So from the red brain. So we can see when this is the venous, the dark line is the venous structures. We can see the significant change of the signals of the venous blood when the rat breathes normal from the switch from the room air to the 100% oxygen, indicating the blood, the venous blood oxygenation levels contribute to the MR signal a lot. But this is just a visualization, it's not quantification, because it's very difficult to really quantify these changes. So the underlying mechanism of that signal changes is because the oxyhemoglobin is diamagnetic and the deoxyhemoglobin is paramagnetic. So we can see the significant drop of the signals. So there are several techniques right now actually available to measure these changes. One is famous, the board technique. It's based on T2 weighted imaging, the T2 star weighted imaging. And also this it's called the calibrated function MR. It's using the challenging the test. And another one is the ability weighted imaging. Another type of the technique to quantify the oxygen changes is T2 based. So first we look at this ability weighted imaging. This is a technique developed by Dr. Mark Hickey in 2004, as we can see. And the beauty of this the technique is very simple, and just apply the face mask to the conventional magnetic image, and we can get this very enhanced the venous structure images, and it's called SWI. So there are a lot of unique features of SWI compared to the gradient echo imaging. So I just want to point to one is it can be a good technique to visualize the venous oxygen level changes because the deoxyhemoglobin play a major role of the signal. So this is the image quite several years ago on 70. We can see compared to this histopathologic study, they used the dye to inject the brain. We got a pretty good, comparable. The images in vivo, especially in the ventricular white matter medullary veins. So, and also, I should say the SWI is very sensitive to the venous blood oxygenation levels. So this is the test that we did several years ago. We got several volunteers. We asked them just to hold the breath for kind of 50 seconds or 45 seconds, and also do the hyperventilation. Just this simple test, we can see already this oxygen, the visibility of the venous changes. So that means the hemoglobin level or oxygenation level in venous blood changes. This same subject, just in a few minutes. So, yeah, it's an indicator of the venous blood oxygen level, this simple technique. And also we did the caffeine test, because the caffeine, we know there's a vasoconstrictive the effect. We use the caffeine pill, and we found the increase in size and the number of the venous structures as compare these two images on SWI, and also we found the decreased the blood flow as we're using the ASL to measure during after the caffeine. So that means the SWI is a very good technique to detect the venous oxygen level. So this is the paper we did in MS, and we found, compared to the controls, we found there's a significantly decreased, the visibility in MS patients, especially in the patients with small lesions. And so we think this is probably related to the mitochondria dysfunction. They don't use a lot of the oxygen, so because of the presence of NO. And also, this decrease the visibility is not only in the lesion regions. So we try to use to evaluate this in a better, quantitative way. We just segment this venous blood voxels using this technique developed by Mark's group, and it's tracking the venous vessels, and then segment them. We found a significant difference of the venous blood voxels in controls and patients. So how do we measure the oxygen metabolism in a more quantitative, a better way? So we think, it has to be measured the venous blood part, because the oxygen level in the arterial side is always kind of like very stable. It's like 98, 96%. And once we know this oxygen saturation in the venous side is called YV, and we know the YA very easily using the pulse oximetry, and then we know the oxygen extraction function, fraction. And also, if we have the oxygen extraction function, if we measure the CBF, then we know the cerebral metabolic rate of oxygen, CMRO2. So we recently developed a technique called T2-based oximetry, T2 relaxation under spin tagging technique. It's called TRUST. So because we know there is a very established good relationship between the T2 in the venous blood and the oxygen levels. So this is the curve showing that relationships, linear relationships. There are several, at least 10 papers on that. And so the difference we measure is we use the spin labeling of the venous blood. In contrast to the arterial spin labeling, we put the labeling band on top to try to label the draining venous blood. So then we put an image slice here, the yellow one, to measure the superior sagittal sinus. This is the big sinus to drain a lot of cerebral blood tissues. So yeah, measure the T2. So once we know the T2 here, for example, we put a cursor here. and we measure the T2. So the reason we do the labeling, spin labeling of the venous blood, because we want to make sure all these the bright spot here in the superior sagittal sinus are venous blood, because they are draining here. All the blood, all the bright spots is flowing because they coming from the labeling, the slab. So this is this way we can exclude totally about the the other tissues, the partial volume from other tissues. So this is the kind of pure measurement of the T2 of the venous blood. So the other technique, there's always a problem is to get the partial volume from the CSF, partial volume from the granular tissues of the venous sinus. So this technique purely measure the venous blood T2. Then we convert the T2 values to oxygen levels. And also we did the test to test the reproducibility different times, very stable. Now we have technique to measure the jugular vein, because we think the jugular vein truly reflect the global, the cerebral blood, venous blood. So also we found a very strong correlation, and so these YV measurements between the superior sagittal sinus and the YV in the jugular vein, because these are the normal controls. And so we measured both the YV in the superior sagittal sinus and also the inpatients and the controls, and also we measured the CMRO2. The CMRO2 measured using the the YV information and also using the CBF. Do I have CBF here? I'm going to, yes, probably here. So the CBF measured, we measured the jugular vein, not jugular, I mean in the neck region, we measure the internal carotid arteries and also vertebral arteries, the 4 vessels. We calculate their, using the phase contrast, calculate their flow, the velocity, and measure the area of these the vessels, and calculate the total blood flow. And using this total blood flow divided by the parenchyma volume to get the global CBF. Once we have the global CBF, then we can get the CMRO2 here. So we found that there's significantly increased YV in MS patients and significantly decreased CMRO2 in MS patients. So this is kind of confirmed our previous studies just by visualize the venous structures on SWI. So these quantitative measures also showing there's significantly increased the oxygen levels in MS patients, or decrease the oxygen consumption. There's some correlations between the YV or the CMRO2 and the EDSS and also the lesion volume. But there is no correlations between the CMRO2 and the brain atrophy. Even there is significant atrophy in these patients. Show this slide. So we think the mitochondrial dysfunction play a major role in this decreased oxygen consumption, as shown here. So the NO inhibit the oxygen uptake by the mitochondria. So we can see flowing a lot of oxygen in the arterial side, but in the normal side, relatively normal side, there's less oxygen left over in the venous side. But in the lesion part or in the mitochondrial dysfunction part, there is still a lot of leftover oxygen. So we think this is probably give you implications or hint of the mitochondrial dysfunction, which can be diffuse in MS. So this is a figure showing we found a kind of like 20% change of the CMRO2, but only the brain atrophy is like 2%, and the lesion volume is only the 0.5%. So we think this 20% change cannot explained by the 2% loss of tissue, brain tissue. So there must be some, other reasons like the mitochondrial dysfunction. So when we see this figure, we can know how important of the vascular oxygen delivery in this in the brain. We can see the density of the vasculature of the arteries, I think here, is similar to the kind of neurons. So once the neurons cannot get immediate delivery of the oxygen, there must be something wrong. This is 2 papers recently and showing the vascular density in the gray matter. So we are going to move to the next part. The second pathway is the neurovascular coupling disruption. It's also called the CVR disruption. So there are a lot of evidence in MS. There's vascular abnormalities. There's blood-brain barrier breakdown. There's the perivascular coughing, and there is a perivenous distribution of lesions. And there's perfusion changes too. Yesterday, the speaker also mentioned the endothelium dysfunction, which also can contribute. This is the cerebral vascular reactivity. Also, the CCSVI, I think, also play a role if there is. And so we want to focus on whether there is changes. There are changes in cerebral vascular reactivity. So, we use the CBF to measure the before and after the CO2 breathing. So we can see here, this is neurovascular coupling, well known. So, we can see once the neural active, there's to join the blood immediately and go back to the venous side. So we have this set up to test this the CO2, the mechanism, because CO2 is also a potent vasodilator and can increase the CBF significantly. So we ask the patients and the volunteers to inhale the 5% CO2 and measure the CBF changes before and after, and also measure the Bohr signal changes before and after. And this is set up, and this is the Bohr signal changes. So we can see the CO2. We also measure the end-tidal CO2, which means the blood CO2 levels. So we see the end-tidal CO2 is kind of changes with the Bohr signal changes kind of change with the end-tidal CO2 changes. When the end-tidal CO2 is higher, the CBF is also increased. So we can use this linear relationship to calculate this vascular response. So this is the map of the Bohr signal changes, mainly in the gray matter. And also we measure the CVR using the CBF, the arterial spin labeling. And we can see this is the control patients and this is MS patients. And we can see there's significant, there is some decreased CVR values in the frontal regions and in the parietal regions. And this is from 8 patients and 8 controls. And we can see this is the baseline before the CO2 breathing, and this is after CO2 breathing. I'm sorry, this is the patient. This is the control group. We can see significantly increased the CBF, but in the patient group, it's not significant, not so much. There is still increase. So we think, in the normal situation at rest, when the neural active, they draw the blood immediately around to deliver the oxygen. This is the part that is called the neurovascular coupling. And in MS, I think it's because of the NO always there, it's always kind of dilate, it's kind of desensitized, and the smooth muscle. So once later on the neural active wanted oxygen cannot be delivered efficiently. So summary of this metabolic hemodynamic impairment and metabolic impairment, we found, the significantly increased YV and decreased CMO2, and also reduced the CVR in MS. So I'm thinking about the relationship between these measures with CCSVI. We found if there is increased, vascular resistance, they cannot drain the blood very well, it can cause the pressure and cause the endothelium dysfunction, and also the CVR probably decrease too. I don't quite understand so the CCSVI with the oxygen metabolism quite well yet, but we didn't find a significant change of the global CBF between the patients and the controls. So this is the regional, the CBF, the studies we did, several years ago, and we found in chronic lesions there's decreased CBF, CBV, and in some, the acute lesions there's increased CBF, and we can see here. And also, one type of the chronic lesions, we found there's also a decreased, increased CBF. This is chronic without enhancing, but still increased CBF. We think this is probably subtle inflammatory activity or recurred in these chronic lesions. And this is 3 types of MS lesions. We also found the periventricular normal appearing white matter decrease perfusion. So, so this is actually it's not for example, these 2 lesions we didn't see the increased the veins on the SWI at all. But in some lesions, for example, these small lesions, acute lesions, there is increased CBF, CBV. Here. So this probably means more inflammatory activity occurs in O and also the vasodilator. So a few slides for the 70 studies. On 70, we can see venous structures very well compared to the 3T, and also we can pinpoint the venules in the cortex regions on the face images, and also a lot of better resolution on the green matter structures. So the lesions relationship between the venous and also the lesions can see very well, and the iron deposition in the deep green matter thalamus can be seen well too. So also we can use this one single technique right now. It's called multi-echo SWI to get both a lot of parameters like T2 star, R2 star, and MRA and MRV, and also the face images. So our results showed, as I mentioned before, the significantly high level of YV decreased the CMR2 and reduced the CVR EMS. This is all probably due to the NO overproduction. And so there are some therapeutic implications, I think, here. Especially to increase the blood flow to improve the oxygen delivery, and I think there's previous studies showing some clinical trials of hyperbaric oxygen therapy, and recently there's statins and acetazolamide. They are all kind of vasodilator or to improve the oxygen metabolism of these therapies. So right now we have techniques. To measure the oxygen delivery and also the consumption. Actually, these techniques, the measures only can be measured in vivo because this kind of dynamic, the process. And we hope, our studies can try to, can link the inflammation part to the neurodegeneration part in MS, which is quite, under investigated right now. So the techniques is CMR2 and CVR. And of course, the first studies were to study the relationship between these measures and NO activities directly, and also the CCSVI. So I would like to acknowledge the team, our team in MS research, and also the Markiki. A lot of good discussions on that. Thank you very much.
Thank you, Dr. Du. Some questions?
Thank you. I appreciate very much your presentation. Your data are really robust, and I think support the idea that MS is primarily neurodegenerative disorders, and probably the immune reaction is secondary, it's not primary. Mm-hmm. But going to the interpretation of your data, mm-hmm. I really know since the inflow is not changed, yeah. and the cardiac output is not changed in MS, yeah. what is your interpretation of your data, your personal interpretation?
Yeah, this is a good question, actually. We want to measure, the global CBF, of course, to calculate the CMR2, because we need that. Also, we want to know whether there is a significant decrease of CBF because the CCSVI. If there is, the outflow is, disrupted, there should be kind of the slow of the inflow too. But we didn't find it significant, but our data is like based on, right now it's 15 patients. But we didn't see the significant the change in these two groups, the global. But we did, as I showed before, we did find the local, regional decrease of CBF changes. And also, I showed also in some lesions there's increased CBF in the local region. So this can be balanced out why there's no significant difference of the global CBF. Another thing is, I think the CVR changes is kind of very local and very kind of in the micro world. It's not global things. You can see, and so there is a collateral, other things, but we didn't see the significant change of global CBF.
Did you measure the area where you found this SWI reduction of the venous vasculature? Did you measure what happened at the level of oxygen and the ventricle side? So you have the same data in the same patients where you're measuring reduction of SWI venous vasculature compared with oxygen delivery?
The SWI, the measurements, not measurements, the visibility of the venous structures is kind of, just the visibility, just the regional. You can see the regional. I showed just several slices, right? Especially in the periventricular region. But the trust technique is to measure the global. It's just to measure the venous, the draining venous sinus blood levels. So it's kind of an indicator of all the venous venous blood from all the brain, and their level changes. So we don't have a good quantitative measure of regional yet. It's kind of very difficult, as I said. There's always partial volume of the venous blood. You cannot really to pinpoint this is venous blood. You can measure the T2 here, and also the other the challenge too. So that's why right now we only measure the big blood, the venous sinus.
Thank you. Congratulations.
Thank you.
Yulin, very nice presentation and very curious that you're able to measure this whole effect globally. So I think Dr. Zamboni was asking if you had seen local effects with SWI, would you have been able to measure it locally? So I would like to say that I'm hoping sometime in the not too distant future that you will be able to use SWI to measure further down into some of the smaller veins and use oxygen saturation then locally, and maybe you could address the local questions. But maybe your data shows it's actually a global effect. So what's bothering me a little bit is, you know all that literature in the last 10 years that's showing that there are apparently, at least maybe in areas of the thalamus and a few other places, there appeared to be local reduction of CBF. Is it possible that the methods we're using to get this global CBF may not be sensitive enough to find the presence of a few regions of local deficits that are in those other papers, and therefore the results would be consistent? Can you comment on that?
Yeah, it's a good question, and I think there's two issues right here. One is we measure the local region. That's we use actually the ASL to measure the whole brain, the CBF too, but we didn't find a significant difference between the patient group and also. And we use the phase contrast, the same technique as you did, to measure the neck, the carotid artery and the vertebral arteries. Those is a very big vessels and the big flow, but in terms of like a capillary level measurements decreased the CBF, as I mentioned, probably due to the NO. It could be decreased over there, but it cannot affect the global. I don't think it can affect the global CBF.
So I guess the critical issue here, as Dr. Zamboni also said, is that the arterial input is still very consistent on the carotid side. But I don't know I forget how many patients you said you had done here with this method so far.
It's 15 right now.
15, well, okay, maybe when you get to the point of 100, you can also collect the data in the neck and do a correlation of CBF as calculated both by the flow technique and by the conventional ASL or PWI methods, and do a plot of overall flow as a function of the total internal jugular venous flow. And you may find that as that jugular venous flow goes down, there is a reduction of total CBF to the brain. But you won't know until you've done at least 100 cases.
Yeah, actually, I'm curious too. Did you measure the blood inflow? I mean, so the global CBF?
We did. We have a poster here on that by Zhong-Yi.
Okay.
And 140 cases we've done there. And there does appear to be some correlation with a subgroup of these people that if the IJV flow drops considerably, so does the average CBF to the brain. So I think we need to have that replicated by some of the things that you're doing.
We better just have one more question.
Yulin, that was a great study. I'm curious which sources of NO you might be invoking here, because we think of this as being an endothelial dysfunction, which means that eNOS might not be available. So I guess that leaves iNOS from infiltrating inflammatory cells, and nNOS. What do you think is really contributing to this large increase in NO that you see? Do you care to comment potentially on the source?
Yeah, I think it's a vascular, mainly from the vascular inflammation in endotheliums produced. As you know, yesterday the speaker also mentioned, I think the NO in the chronic stage or later phase it can be decreased, but I think the damage effects can always kind of happen earlier when there is consistently high NO over there. The NO actually is good in many things. I mean, so, but if it's consistent over there produced, it can decrease the mitochondrial dysfunction and also decrease the CVR.
Thank you very much.
Yeah, thank you.
Our next speaker is Dr. Zavadnov, professor of neurology at Buffalo and our current president of our society.
Bart, great pleasure, and thank you for the invitation to be here presenting this talk on perfusion changes in CCSVI. I was really appreciating your talk, Dr. G, and clearly I will try to address, at least from my perspective, some of the questions that have been raised in the previous talk. So these are my disclosures in relation to overall research on CCSVI and other relevant areas. Now, clearly, I would like to talk first about perfusion damage and oxidative stress as a possible consequence of reduced capillary bed flow due to CCSVI. So we already heard that several studies have reported hypoperfusion of the brain parenchyma in MS patients, more on a regional basis, which also could precede disease onset, so not just in the later stages of the disease, very early. Changes in perfusion MRI are very relevant for neurodegeneration and probably for a hypoxia-like condition in MS. It has been shown in many studies that both in normal appearing white and gray matter, several perfusion indices are decreased or increased. At the moment, clearly, as you heard in the previous talk, it's very debatable what's leading to these local perfusion changes, whether they are due to the chronic inflammatory events or could be due to the secondary hyperemia of the brain parenchyma, due to hemodynamic abnormalities. However, this is definitely not clear, and we clearly need to understand better what's leading to this reduced perfusion in the white and gray matter of patients with multiple sclerosis. But I would like to call in question, in collaboration with, and would like immediately to acknowledge Clive Becks, who is not with us today. Unfortunately, he was supposed to speak on this event, but got a broken ankle. And I really am learning a lot from him about, mechanism of perfusion and fluid dynamics, and clearly this is helping in interpreting some of our data. But one thing is true, as you heard, the transfer of the nutrients from the capillary bed into the brain is proportional to the blood flow through the capillary bed. So the capillary bed is extremely important for the question we are talking about, both in terms of MS and CCSVI. And any obstruction of the extracranial venous drainage pathways may significantly reduce the supply of brain nutrients and potentially result in hypoxia. So if we remove an obstruction in the internal jugular veins or azygous vein, the question is, could that increase blood flow through the capillary bed with consequent increases in transfer of all this oxygen, glucose, and nutrients into the brain, and whether this may help to immediate temporary reduction of subjective complaints of MS patients like fatigue and cognitive impairment, as has been recently mentioned in 2 studies. So the real question is, how acute would the venous hypertension have to be to cause a disruption of the blood-brain barrier? And also, what percentage of reduction in blood flow through the capillaries would result in sufficient brain tissue hypoxia that a significant percentage of the oligodendrocyte cells began dying? So I think that nobody has answer to this question. So in a very pilot study with Professor Zamboni group, we tried to answer some of these questions. We investigated whether impaired venous outflow is related to hypoperfusion. This is one of the 5 studies that we published on so-called chronic venous insufficiency study in multiple sclerosis. We had 16 relapsing remitting patients and 8 healthy controls with disability between 0 and 5.5. And here are the common exclusion criteria for this study. So all data have been assessed in a blinded manner. The Italian researcher performed the Doppler, and the Buffalo ones performed clinical and MRI examinations, and the study was approved by the IRB. So all the subjects obtained the Professor Zamboni CCSVI criteria. At that time, they were not yet revised. This was a study that started in mid-2009, actually 2008. And we also, for that study, created a so-called severity score, which we call VHS-ISSS. So in terms of MRI protocol, we did normal sequences for MS, T2, T1, gadolinium, and also 3D-dimensional T1. And perfusion imaging was done with dynamic susceptibility contrast enhanced perfusion imaging. It was a single-shot gradient echoplanar sequence. The analysis was pretty straightforward, done in all these structures, in gray matter, white matter, caudate, putamen, globus pallidus, thalamus, and other deep gray matter structures. We measure cerebral blood flow, blood volume, and mean transit time with an automated AIF, arterial input function algorithm, and CBF and CBV values were relative based on estimated tissue relaxivity and hematocrit parameters. So these are just examples of the T2 segmented images as well as CBF, CBV, and MTT maps. So mean age was 36 years, meaning disease duration 7.5 years, and patients were mildly disabled with EDSS of 2.4. In the study, all patients resulted to have the CCSVI and none of the healthy controls, with a mean of 8.9 for severity score. The main outcome of the study was that in all these regions that I'm showing on the left, there was a very strong correlations that persisted also after false discovery rate correction. So you can see the p-values and the q-values between severity of the CCSVI and changes in perfusion measures. Most significance has been seen in gray matter, white matter, thalamus, putamen. Clearly, you can see that there were strong correlations also for mean transit time and cerebral blood volume, but they did not result significant. Just so you see how the patients behaved in a graphical way, this is the gray matter, CBF, and this is the white matter, CBF. So very good distribution of values respect to severity of the CCSVI. We looked also patients on individual basis and found really remarkable images in those who had very similar disease duration and but had no very low or very high severity score on CCSVI. So this is a patient with 33 years and with 36 years, so very similar, identical disease duration. You can see somewhat higher, 1 point higher EDSS, and remarkably different perfusion based on the number of areas that have been obstructed, both in cerebral blood flow and mean transit time. So, altered cerebral blood flow CBF pattern may not only be a consequence of local circulatory disturbances due to inflammatory mechanisms, but also may be a result from outflow blockages situated far away from the lesions. Probably CCSVI may impact local hemodynamics at places which are distant from the location of the mechanical stenosis. Such mechanisms may lead to the capillary hypertension and leakage, which I will address in the second part of my talk. We showed a strong relation between the severity of CCSVI and all these structures, and clearly it cannot be excluded that venous anomalies are only secondary to reduced perfusion and that all we are finding is a consequence. However, the role of CCSVI has to be further studied with respect to the perfusion of the brain. This was, to the best of our knowledge, the first pilot study that investigated hypoperfusion and CCSVI in the brain parenchyma. And clearly these data are from a very small group of subjects and need to be confirmed in larger cohort. Clearly the particularly strong correlation in the deep gray matter needs to be further explored. We also looked at the healthy controls and the severity of their CCSVI scores and found no correlations at all. So the second 33 minutes I'm going to spend and hopefully make the debate really hotter about a relationship between the CCSVI and venous vasculature. So you already saw this slide, and Dr. Guy was really inspiration to us when we saw this paper and begin our work. You can see that clearly there is a big difference between patients with progressive relapsing remitting and healthy controls, just looking visually the visibility of the veins on susceptibility weighted imaging at 3 Tesla. So our early work in 2009 was to reproduce Dr. Guy findings, and this is a healthy control, relapsing remitting and secondary progressive patient, and just by watching this you can see that there is very big difference in the vasculature of these 3 groups. In this early stage, we did a number of experiments by using gadolinium contrast. You heard that breathing, caffeine can change the visibility of the veins in the brain, but gadolinium can change even much more visibility of the veins in the brain. So we did single dose, double dose, triple dose of contrast, delay of 5, 10, 40 minutes. And for the sake of the shortness of this talk, I can show you amazing images how many veins you see after 40 minutes and triple dose of gadolinium. But what we established with these development studies is that if we give a single dose of gadolinium and we wait between 12 to 15 minutes, which was done in the study that I'm going to present you, we increase exponentially amount of the veins that we see. So this paper was published last year in BMC Neurology, in which we developed a number of parameters from this work, from these minimum intensity projection map images, calling it apparent venous volume maps, maps of different vein sizes, and so-called average distance from the vein, which is amount of distance to every vein from each voxel of the brain. 59 MS patients and 33 healthy controls participated to this study, of which 41 have been relapsing remitting and 18 secondary progressive. For the sake of time, I'm not going to enter into the details, but the data were expected both as supposed to be between MS and healthy controls. There were agents X-matched, as well as between relapsing remitting and secondary progressive patients. In terms of the CCSVI, 18% of healthy controls and almost 80% of MS patients in this particular study had CCSVI. As well, you can see that severity was strikingly different. A trend for secondary progressive patients was found, and no difference in severity between RR and SP in this study. One of the main outcomes of the study was that we found that MS patients have decreased about 20% apparent venous volume, which means all visible veins in the vein in terms of milliliters compared to healthy controls. And that was also for those smaller veins. And one of the most significant things was increased average distance from the vein, which is indicating obviously less veins in the brain, or less visibility of the veins in the brain. No differences have been found between RR and SP patients. When we divided all subjects, independently if they have been in control or MS group, in those with CCSVI and no CCSVI, you can see that subject with CCSVI, as well because the healthy controls had the CCSVI, had significantly lower apparent venous volume, volume of veins less than 3 millimeters, and average distance of the vein. When only MS patients were considered, the average distance of the vein has been higher in those with having CCSVI. Now, I have to stop here for a second, because in the paper there is a whole analysis published with gadolinium. So we did show that the apparent venous volume of the veins in MS patients was very similar, almost equal, if you did the pre-contrast SWI venography or you did post-contrast SWI venography after a gadolinium injection and 15 minutes of wait. In our opinion, this suggests that probably there is not just a metabolic change here, but that truly these veins may have disappeared from these areas. When we did the same experiment in 8 healthy controls in this study, there was significant increase in amount of veins that we observed after giving injection of gadolinium. So we saw more visibility of the veins in the healthy controls. Now, one of the main findings of this study was extremely good correlation, as you can see here, between the severity of the CCSVI and decrease of the visibility, again, with average distance from the vein driving having the highest Spearman correlation. You can see also that there was a good correlation between severity of CCSVI and T1 lesion volume. I have to say that we presented another abstract at ECTRIMS in 2010, but never published yet the study in which we correlated the perfusion in these patients with visibility of the vein, and we could explain only 25 to 30% of decreased visibility by the changes of CBF, CBV, or MTT, which is suggesting, in my opinion, that not all decrease of visibility of the veins in the brain is just related to hypometabolism as measured to the perfusion-weighted imaging. Now, this study clearly suggested that there is some association between severity of CCSVI and decreased visibility of veins on FSWI venography. As I told you, the pre- and post-contrast experiment, in our opinion, is very important. We clearly are, for the first time, associated the presence of substance of CCSVI with a decrease of visibility of the veins. And MS patients with higher number of stenosis had also more significantly decreased visibility on venography. And this is supporting both our perfusion study as well as the CSF flow study that I will present later. So my final thoughts on this problem are the following. In my opinion, the reduced visibility of the veins in MS is superposition of two main effects: reduced metabolism and probably reduced venous vasculature. Now, why there is no decreased CBF flow, CBF at global level, as Dr. Guy is suggesting, is to be determined. But I would not expect the CBF at the global level to be decreased, because then the lesions should be all over the brain, and they are not in multiple sclerosis. That's why we see the local changes. Now, if we see, and these vessels that are decreased, they are not decreased on a global level. They are decreased on a local level. We said in this study and in the paper that there should be a regional SWI venography analysis done, which will offer a deeper insight into pathologic mechanisms of CCSVI. In collaboration with Clive Beggs, we are working on models in which this blood that cannot be drained anymore from the small vessels is probably rerouting to the large vessels, and then these large vessels have a job to take this blood out of the brain. Now, how this really coincides with the CBF is something to be looked at, but our working hypothesis is that major vessels are taking blood from the vessels that can do it on a very local, small basis. So clearly, why this is not leading to hypertension is probably due to the chronic process of this problem. It does not happen over one day. And B, we can't, and I applaud Professor Hackey's comment, we can't forget extracranial collateral circulation, which is kind of developed to take much more blood than if jugular veins would be able to take alone. So I think that interplay between occlusion in the venous vasculature and development of central atrophy due to the also cerebrospinal fluid altered dynamics may play a very important role into this. In prospective randomized endovascular therapy study in MS, we are doing MRI perfusion and CT perfusion by 360 slice with Professor Siddiqui, and I would say that Professor Siddiqui is a world expert and University of Buffalo in doing CT perfusion. Actually, they really invented 300 slice CT perfusion. We are doing that at 0, 30, 90, 180, and 36 days in both placebo and treated patients in a totally blinded way, and I hope that this will give us insights. I'm over the time. Just would like to thank Professor Zamboni and the Italian group for this really great effort in doing these first studies, and clearly we are open to collaborate with anybody else on this argument, which I think is central to understanding of the CCSVI. Thank you.
Thank you, Dr. Vago. Questions?
amazing results. But, you know, your findings in terms of brain are exactly the same which is visible in the settings of chronic leg ulcer in the skin, in the lower legs. Also, because in this area, the investigation is much easier because we can just make a histological study in a living object. And we see this appearance of small veins, but the global flow in this area is the same. So it is exactly the same. It's just a sign of the chronic venous insufficiency, but in different organ.
I would agree with you. I don't know much about the legs, but...
But it's exactly the same.
Okay.
Yeah, I think it's a great work. I mean, so can I have the microphone?
Can we have a microphone?
Yes, fine. So it's great work, and
Thank you.
I'm very interested in the contrast, using the contrast agent to enhance the visibility of the venous. So I'm curious, what kind of size of the veins you didn't see drop of signals in patients?
So we began to see less than 0.6 millimeters with you mean in total or in just in the pre-contrast?
Global level, big size of vein or just the kind of very small size?
So there are two studies now that we have. One is the study that we published with BMC Neurology. Another study is a study that we are underway to publish with Professor Becks. In this study here, we found apparent global total venous volume decrease as well as those of the smaller veins less than 0.3 millimeters. In the study with Dr. Beggs, we are finding that most affected are those between 0.3 and 0.6 millimeters. On another level, we are taking this discussion further to more technical level, developing a different algorithm from what we did with phantom and simulation experiments, trying to assess how much partial volume effects is playing into this, and all technical issues that have been raised during the review of our BMC neurology paper. So I think that we definitely need to do better. Although the reproducibility as published in BMC was very good, we need to test the accuracy of this segmentation. Obviously, when you give the contrast, and that's what has been published in BMC neurology, your reproducibility is significantly higher than with pre-contrast.
Yeah, because I didn't see the images. I don't know what kind of size of veins, big size.
I show it on one slide, but it was just too many pictures.
Another question is the patient group with CCSVI and without. Did you find a difference on the after contrast?
Oh yeah, the difference was even bigger than with pre-contrast. That's published in BMC Neurology. There is a table regarding that. I know we are out of time. One more question.
Oh, thanks. That was a great study. One of the things, harking back to the early 90s when I was actually looking at the microcirculation of the cerebrovascular circulation, one of the things we actually found when we were actually doing venous occlusion, which is, believe it or not, quite difficult, is that typically when the arterial side, when we actually measure it, it's actually entirely responsible for controlling flow based on oxygen saturation. And so that may be one of the things that may be very useful to add in there. Like right now we're kind of focusing on the loss of venous circulation, but what we typically saw when we did these is that when we occluded a retinal vein and we actually went and looked at the increase in pressure, what we found is that the increase in pressure was very low, but the oxygen saturation around there didn't really change because it was entirely controlled by the arterial circulation. So what might be really useful would be to look at the arterial side, subtract the venous side, and then you actually get an entire picture because the arterial side controls the flow, which is what we're seeing as the flow remains normal, but the venous vasculature drops down because you get these big monster collaterals that take over. And so that's why the venous circulation, you don't see it and it drops out. So it might be quite useful.
Yeah, I think that's correct, and I think that Professor Haki is already working on that, and we are trying to.
So The next speaker is Dr. David Harper, and his topic is functional MR board and ASL perfusion before and after venoplasty.
Dr. Zavadnov has made it clear that we ought to be saying clearly that when we're doing research where the patients are paying for their own studies. So all the studies that we have done in San Diego, these are patients that are not, there's no external source of funding. The patients are coming for testing and for treatment and paying for it themselves. This is a study that we've submitted with Mark Keiki and Gidrius Barakis, who is a PhD in neuroscience at UCSD. BOLD, so I run an FMRI BOLD center. So BOLD, it depends on the fact that when you activate the cortex with a cognitive, emotional, sensory, or motor task, it calls in a surge of blood, a localized surge of blood, and then that surge of blood leaves, and the change from oxygenated hemoglobin to deoxygenated hemoglobin is detectable because deoxygenated hemoglobin is paramagnetic. So that's the basis of BOLD. So basically, it's a very good way to look at venous flow in the cortex. So I devised a task called the tell time task, where a person looks at a clock and hears a time of day and has to decide whether the time of day they hear and the time of day they see is the same time or not. So it's a visual task, an auditory task, a motor task, and a cognitive task. So you get to look at the entire cortex. What I reasoned was that if there in fact is poor venous drainage, then the outflow of blood from a BOLD response. The BOLD response is a surge of blood in, and then it drains back out again over 20 to 60 seconds. That if that were true, what's called the venous undershoot, which is the depth and duration of the leaving of the blood after an area of activation, should be prolonged. So this is what we got. And these are hard slides to look at, but a lot of these slides to look at. So a normal subject, this shows the area of activation to a normal subject on the left. See, is this working? On the left. So in response to this task, obviously you're going to see visual cortex activation, so that's what we're seeing in this area. And then you see the area, the temporal areas where the auditory response is, the frontal areas where you would have the executive decision. And also, this is a really nice picture. This is in 20 subjects, 20 normals, of the default network. So the default network in the fMRI world is sort of the hot topic. The default network are the areas that actually get suppressed when you're doing a task. It's sort of the resting area of the brain, only it's really not resting. It's probably taking care of housekeeping, of daily issues. So these areas, the midline frontal, midline posterior, and parietal areas, this is a real classic example of the default networks. In MS patients, before they've had venoplasty, the default network is virtually gone. There's a little bit of medial prefrontal activity left. Overall, there's less activation overall, and in particular, there's loss of the default network. After angioplasty, so this is the next day in these 20 subjects, the default network returns. In fact, it returns essentially to normal. In addition, the task-positive areas, the visual cortex, the temporal and frontal cortexes, they improve, but what it improves most dramatically is the return of normal function of the default network. So looking at it, looking at the same data, only now kind of really focusing on the this slide is the comparison of controls to pre-angio patients, and then on the other side we see comparison of the patients post versus pre. Right? So you see clearly the return of the default network. This was highly statistically significant. Looking at it from the number of voxels, so that was a visual picture. If you now actually add up the number of voxels that we were seeing in the last slide, you see it with the task positive, so that's actually doing the task. You see that after venoplasty, so this is literally the next day, so obviously this cannot be explained by atrophy or some other kind of lesion load model. You see an improvement. This improvement in the task positive areas, as you could see visually, was not quite statistically significant, but in the task negative, so that means the default network, essentially it returns to normal a day after the procedure. This is looking at the actual bold response. So what we do with that, we show one picture, we give them one task, and then we give them 8 tasks in a row. And so what you see then is this is the response to one task, and you get a little bit of a venous undershoot, and then this is this is what's called a block design, so you have the person as fast as they can do it several times over a period of time. And this is a pretty classic normal-looking bold response. This is called the hemodynamic response. You see a surge of blood coming in, a kind of a plateau while the task is going on, and then it drops back to normal, only it doesn't drop back to normal, to baseline. It drops back below baseline. That's called the venous undershoot. So here what we see is that the dotted line is pre-venoplasty, and the black line is post-venoplasty. So statistically, this was a highly statistically different change. It doesn't look that dramatic when you look at it comparing. So the red line is pre-venoplasty, the blue line is post-venoplasty, and the black line are the normal groups. But in fact, it's a highly significant improvement in venous undershoot. So this cannot be explained by placebo effect, of course, cannot be explained by atrophy, cannot be explained by lesion load, and it correlates nicely that a change in the extracranial jugular flow is mirrored in a change in venous drainage in the cortex in response to a task. What we're working on now is arterial spin label and perfusion. We're just kind of moving on. We've only done 10 normals and 10 patients. Arterial spin label perfusion, I like it because you don't have to use gadolinium. So we can do it every day. My son, who has MS, we do it every day. So we can actually really see what's going on. We have no problem doing it the day before and the day after a venoplasty, which we would not want to do with gadolinium. Basically, you magnetically label the water, the protons, coming up through the neck, and then you measure that labeled proton by having changed its magnetic qualities. You can then follow it voxel by voxel, slice by slice in the brain. So it's very short, it takes 6 minutes. So it's a really nice test. So my question is it a way we can look at whether or not something happening in the neck is in fact causing hypoperfusion? So we know from 5 or 6 studies that there is hypoperfusion in MS. The neurologists tend to want to blame that on atrophy and neurological disease, and that's been discussed, and I think most people say no, it cannot be simply explained in that way. So what we do, so perfusion, you get a general measure of a lot of clinical sites will do perfusion studies. They're doing it for stroke. So it's a pattern, it's a visual thing that the radiologist looks at and says, yeah, that looks abnormal. So what we do is we segment gray matter from white matter. It's quite elaborate. It takes Dr. Gidrius, a PhD, several hours to do it. And then we actually measure the mean gray matter flow, at the mean white matter flow, and then separately the gray matter white matter boundary. So this is one subject. We have not done our group analysis on the 10. Normal is 60 to 50 milliliters per 100 grams of tissue per minute. PET scan, dynamic contrast, perfusion, the way that Dr. G and Mark Hakey do it, and ASL don't have exactly the same results. But in general, normal should be gray matter of about 60 milliliters per 100 grams of tissue per minute. White matter should be something like 40. You hear that it should be half of gray matter, but as I look at the literature, it's really more like 60 versus 45 in that range. So in this MS patient, the gray matter was 37.49. The white matter was 24.61. So low, I mean bad, right? I mean less than half of what normal flow would be. So this is the gray matter on this side. Basically, the mean is the red. This is basically a histogram for the different flows that you could have, ranging from a flow of 0 to a flow of 100. How many voxels are having that flow range? This is what the images look like. So this is this is a patient. This is the same patient pre-angio, the day before venoplasty. And these are the slices. So it gives you sort of a feeling for what you see. They're a little bit hard to look at, but basically what you see is there's a great range of distribution of the areas that have very high flow and the areas that have very low flow. It's not a simple picture. When I first started doing this, I was expecting to see the cortex all red and the white matter all blue, and as you can see, it's not quite that simple. This is the white matter. What I was sort of hoping for, you might say, is that the periventricular white matter would have the lowest flow. Well, it seems that is the case. I'm going to go by that slide. The gray-white matter boundary, once again, kind of hard to look at, but you see the ranges of how variable it is, where you have increased perfusion and where you have decreased perfusion. I think in a simple-minded way, I think we might have thought before we got into this line of work, it would be much cleaner than that. Why should different areas have such different blood flow? I think it's related to this question, and we're going to see that after venoplasty, in addition to increasing perfusion, you redistribute perfusion. It changes the areas that are being perfused. So this is now post-perfusion. So visually you can see that it's somewhat changed, but also in particular, gray matter is now 37 per 0.8 milliliters per 100 grams of tissue per minute. White matter is 30. So not a huge change. Would have been great to see that gone up to 50, 60, up to what our normals look like. So it's gone up a small amount. The pattern of it is changed, and you can't see that unless you had both of them side by side. So we actually have putting them together. So this is a slide of comparison of post versus pre. So what you're seeing here is post-angioplasty, there are a number of areas that show dramatically increased perfusion, and some areas, so blue, is decreased perfusion. So even though overall there was a minor increase in perfusion of all gray matter and all white matter, what this is showing is that going slice by slice, voxel by voxel, some areas had decreased perfusion and some areas had increased perfusion. This is a similar map, only we're using a statistical t-test to give us that same information. So in this one, red is statistically significant increase in perfusion pre versus post venoplasty, and blue is statistically significant decreased perfusion pre versus post. This is kind of putting it all together. This is my last slide. So green is the perfusion, the number of voxels pre. Yellow is the number of voxels post for gray matter and for white matter. So for gray matter, it was actually not statistically significant. The p-value was 0.5. But for the white matter, the increased perfusion in white matter after venoplasty was in fact statistically significant. So this is one subject. Obviously, we now have to do this in the group. It's taking us a while because we're not seeing. It would have been nice if the redistribution of perfusion was all in the same places. It was always increased in the thalamus and decreased in the basal ganglia. Just eyeballing it seems like it's variable. Well, I don't see yet a pattern as to why one area is having increased perfusion and not. But hopefully when we do the group data, maybe we will see patterns. And also, once again, this is only 10 normals and 10 patients pre versus post venoplasty. So the BOLD clearly showed a change in venous drainage. That change in venous drainage normalizes. The MS patients, their BOLD measures came to the normal level, to the same levels as the normal subjects. ASL perfusion, we're just getting started on it. I would say the main finding is perhaps a small increase in perfusion, but mainly a redistribution of perfusion. And that these cannot be explained the way neurologists want things to be explained, either as a placebo effect or by atrophy. Thank you.
Thank you for this nice presentation. It's Mamoun from Jordan. Do you think this change in perfusion might be related to the medication we give during angioplasty and after angioplasty, like heparin or vasodilators? Do you think there's any role for this in changing the perfusion pattern after angioplasty?
I never even thought to ask that question. The heparin ought to be, but the half-life of heparin's minutes.
It has a vasodilator effect, the heparin itself.
Yeah. So we don't. The only medication we use, our IRs use, is heparin, and they use it for about half an hour. They're not using any other drug. Interesting, though. I mean.
Yes, Bill Code from University of British Columbia. Congratulations again. You know, it's a really elegant study, and I think this kind of work is really going to help us a great deal in helping people understand it, especially those of us with multiple sclerosis. I wanted your impressions also, you know, for anybody that ends up with needing a reintervention or seems to not be doing as well. Is it track that you're able to market here and then able to then again show re-improvement, those sorts of issues? Or for perhaps someone that you followed long term, are you able to notice subtle changes and then they turn up in sort of clinical complaints?
Boy, wouldn't that be great. I mean, life is just not going to turn out that easy. I would have expected ASL perfusion to be very stable, like a structural scan, as opposed to what I do mostly, which is BOLD, where a change in whether you have an itch, you can get a different BOLD response. It's very reactive to cognition, et cetera. I was expecting perfusion to be less so. I think I was wrong to expect that. There's another technique called functional ASL. You can do, is that anything you looked at all? Functional ASL?
That's the reactive difference?
Basically, you use ASL, but you use it instead of BOLD. So you do a cognitive tasks only instead of or in addition to looking at the deoxygenated hemoglobin response, the BOLD response. You can also look at the perfusion response to get more information. So I've done my son every day for 2 weeks. There's some fluctuation to it. I think coffee is really key. We know in BOLD you've got to tell patients not to drink coffee for a few hours before you do BOLD. I really don't think I appreciate that, the importance of that as much. You have to do the same thing with ASL. So that would be great, wouldn't it? Since we know the MRV flow quantification has not been all that what we hoped, right? I hoped that after venoplasty, everyone's combined internal jugular vein flow would increase from under 7 to over 12. And that has not been the case for us. We have not seen that you always see an increased flow in internal jugular veins after the procedure. So yes, I'm very much hoping that we'll be able to see over time that perfusion may be another way of getting at actually what we really want to know, right? We want to know whether the brain is getting cleared or perfused adequately as opposed to the neck. Another thing is, I think people use the word cerebral blood flow and perfusion synonymously. At least with ASL perfusion, they are not synonyms. ASL perfusion is measuring the movement of water through parenchyma, not the movement of blood through vessels. So I think it could be a great measure, but with the luck of things is it's going to take Robert Zavadnov's lab and millions of dollars to really tack this thing down over the next 10 years.
Yeah. And just one other comment on the previous speaker's question. The heparin is interesting because it affects factors 10 and 11, and we're not sure how long it affects it for. It can affect it for 24, 48, 36 hours to a degree. So the odd person with hypercoagulable blood, it could make an appreciable difference. So it would be really interesting to see the occasional person maybe 3 days or a week out, just to take that factor out of the possibility of equation.
Yeah. All right, we're way over time, and we have posters to look at. Thank you.
Thank you.